Idaho Matters podcast is brought to you by St. Luke's On-Demand Virtual Care, which allows patients to see a provider from their home using a computer or smartphone with on-demand care for common ailments, such as a cough, sore throat, or a sinus issue. More information at stlukesonline.org. From the studios of Boise State Public Radio News, I'm Gemma Gaudette. This is Idaho Matters. Recent changes at the U.S. Department of Health and Human Services are raising concerns about future access to some vaccines. Now, the agency, headed by Robert F. Kennedy Jr., has started limiting the approval and use of a few vaccines, including Kennedy's decision then last month to stop the recommendation of the COVID vaccine for children and pregnant women. And those decisions, along with removing all 17 members of the Advisory Committee on Immunization Practices and replacing them with vaccine skeptics, has many states and private organizations now working to make sure people can have access to vaccines they need. So joining us today to talk more about this is Dr. David Pate, former CEO of St. Luke's Health System, and the co-author of the book, Preparing for the Next Global Outbreak. Hi, Dr. Pate.
Hi, Gemma.
And folks, remember, if you do have a public health question, send us an email at idahomatters@boisestate.edu. So, Dr. Pate, last week we spoke about these new members of ACIP meeting. They met last Wednesday and Thursday. That meeting has wrapped up. What were some of the decisions that stood out to you?
Probably the thing that I can't say that I'm surprised, but I feared would happen, happened. And that is, first of all, the two people chosen to be co-chairs of the committee were like the worst possible choices for those of us who care about science and vaccines. Second, the decision that I'm referring to that I'm not shocked about and I feared is that they said they're going to create two more work groups, one to review the immunization schedule. And what that means is we're going to see a wholesale attack on all vaccines, probably. The second thing, which is really just scientifically ridiculous, is they indicated any vaccine that hadn't been studied, I believe, in the last 7 years, they are going to have this work group focus on restudying. Now, that may sound like a very logical thing to do, but for scientists and physicians, it's ridiculous. First of all, we already know the answer, and to whether they work or not, we've got the data from all the years it being in use, and we accumulate lots of safety data, so we have that information. But if you were to start from scratch to restudy any of these vaccines, some of these vaccines have pretty much wiped out the diseases that they're being used to treat, and therefore it would take huge numbers of study participants to start from scratch to reassess them, and it would be extremely expensive. And my fear is this is merely a ruse to say, okay, look, see, they can't do a study, we're just going to have to withdraw our support for the vaccine, and that's just going to be ridiculous.
So, Dr. Pate, even though the group did recommend the flu shot and RSV for the RSV vaccine for babies, this hasn't eased the minds of many health experts. So, can we begin with the American Academy of Pediatrics, who late last week said that they will start publishing their own vaccine recommendations? Now, I'm assuming, Dr. Pate, that has to do with this work group that's being formed to look at when vaccines would be given to children.
Yeah, I think that's right. I think we all know what when the new co-chair announced that work group, we know what that's code for. And so does the American Association of Pediatrics. And they before we had the ACIP and CDC publishing vaccine recommendations, the American Academy of Pediatrics used to do this. They've been doing it
Hmm.
for 90, 95 years, something like that. And so I was thrilled to hear that they're going to take this on. There are other groups that are also talking about taking this on. And frankly, I hope that maybe they'll bring these groups together to work in concert. And frankly, if we were to do that and bring renowned experts from all of these disciplines and representing these various different organizations, really we could make ACIP fairly meaningless, especially now that the largest health insurer coalition has come forth and said they're going to trust the science for their coverage decisions of vaccines and not necessarily go with what ACIP says, which is a departure and
Hmm.
very reassuring one.
Well, and Dr. Pate, talk a little bit more about that, because my understanding is that insurance companies normally go with the CDC recommendations of what vaccines, are covered. So therefore they will cover them. With the largest, insurance, or organization coming out and saying, okay, we're going to follow the science, I would assume they are going to now, this organization, go to insurance companies and encourage them to cover these vaccines if things like the American Academy of Pediatrics is taking their recommendations versus taking ACIP's recommendation. Does that make sense?
Yeah, I think that's right, and I think that it makes sense because up until now, the insurance companies, since 2010, I think, have been going with ACIP's recommendations as to what vaccines should be provided at no cost to their members. But what insurance companies also know is that there is a return on investment for keeping people healthy and preventing disease. It is far less costly for an insurance company to pay for a flu shot and cover that than it is for a baby or an older adult ending up in the hospital with complications from the flu. Same thing for
Mm-hmm.
RSV, other things. And so I think there's an alignment there, and I was just very reassured to hear that that's what they're going to do. I even hope that with these perhaps medical organizations coming together, there can be some representation from the health insurance industry, because we need to get collectively around the science, what helps people, the benefit, and let's try to make it accessible for them. And the biggest accessibility issue for a lot of people is cost.
So, also talk to us about what some states are now doing after this meeting last week, Dr. Pate. For example, 9 states have banded together and they've now created the Northeast Public Health Collaboration. So, these are 9 states in the Northeast part of the United States. Why are states beginning to make these moves as well?
Well, the states have a lot of interest in this because, first of all, we have seen what the impacts are of communicable diseases in various states. If these are not controlled, what it leads to is school closures. It leads to working parents not being able to go to work because they're staying home taking care of a child, or perhaps that parent is very ill. The data is very clear what happens to work productivity with these illnesses. And now we are seeing concrete evidence that where everybody kind of blew off COVID, we are seeing the effect of the disability among people in those states that have developed long COVID, other complications. And it's just not good for their economies. It's not good for the health of their citizens. And if you let vaccine preventable diseases go unaddressed, it will overwhelm the state's hospitals, and so states have a lot of interest in this, and I'm pleased to see that really we're seeing them, some of them, not all of them, of
Hmm.
course, but we're seeing some of them respond in very meaningful ways.
So, Dr. Pate, if you are a parent or a caregiver and you have a kiddo and you want them to be vaccinated, what do they need to know here in Idaho? I mean, how do they now move through this system? Because, for example, what I did with my kids is, I mean, I followed, the vaccine recommendations. I would make those appointments with our pediatrician. We'd go in, we'd get the vaccine. I didn't get a bill. I moved on with my day.
Right. Well, first of all, the vast majority, of course, we do have some exceptions, and we've talked about that over the years, but the vast majority of physicians in Idaho follow the science. They believe in vaccines. They vaccinate their own children. They've seen the difference it makes. And as we've discussed before, the very fact that younger physicians in practice today have probably never seen a case of mumps, a case of
Hmm.
diphtheria, a case of rubella, etc. We know that they work because we have gotten to the point where we rarely, if ever, see these diseases that we can successfully vaccinate against. So you still have your doctor. Talk to your doctor. Second, of course, I suspect you and I will continue to talk about the changes and vaccines, and I'll be continuing to write about it on my blog. But also, as we just said, you can look to the American Academy of Pediatrics for recommendations. You can look to the World Health Organization. There's going to be a number of these places where they can get good, reliable information. And I'll even try to list some of those in my blog when I can get up to restarting writing again
Hmm.
following the death of my wife. So I'll be doing
Yeah.
that soon.
So, Dr. Pate, the other thing I want to talk about before we go to break is the flu shot. So, this group, they did recommend the flu vaccine with a caveat, and you talked about this last week. But for folks that maybe weren't with us last week, they they are not recommending a flu vaccine containing trace amounts um, of a preservative. I'm going to let you say it because I don't want to say it wrong, that's rarely used anymore. But as you explained last week, it's sometimes added to vaccines for sterilization purposes. So, can you start out by explaining what this is, and frankly, the misinformation that ACIP has raised regarding this recommendation?
Yes. So what you're talking about is what lay people will just refer to as mercury. What it actually is a compound chemical called thimerosal. And it used to be prevalent in vaccines decades ago because it could be added to the vaccine to prevent a bacterial or fungal infection of the vaccine, especially when people have multi-vial doses where you have to stick needles in it and withdraw a dose for multiple doses to be given from that one vial. Well, uh, there was all kinds of concerns that maybe thimerosal was causing autism or other problems, and research has been done and has conclusively demonstrated, if you have an open mind and you're willing to look at evidence, that it is not associated with harm. However,
Mm-hmm.
because it was made such a big deal, and because it was less and less important as we got better at formulating and making cost effective single dose vials or single dose syringes prepared, it's been less important to have it. And frankly, it was just voluntarily phased out of vaccines, so that right now about the only vaccine that has this is a multi-dose flu vaccine that has it, and that's what they spent their time on, which was time wasted. But nevertheless, at least this decision isn't really a big harm because, frankly, it accounts for about 4% of the flu vaccine. Most of the flu vaccine doesn't have this in it, and most of it is single dose or prepared doses. And so, them saying they don't want to use that anymore, there's lots more things they could have done to cause harm
Hmm.
than that. And it's just nonsense. People, but it does stoke this continuing flame of, because if you tell a parent, well, there's mercury in that vaccine, of course, everybody would be alarmed. As it turns out, it is a very small dose that's in a completely different form that really can't be significantly uptaken by your body and stored, unlike the mercury we warned pregnant women about in fish, that kind of thing. But so it's much to do about nothing, but thank God the other flu vaccines are approved. That will get us through. That will be fine.
Okay, so yesterday, the U.S. Senate narrowly passed the so called Big Beautiful Bill. It now heads back to the House of Representatives for a final vote where they cannot make any changes. But if they vote in favor of it, this bill will pass. If it passes, there will be steep cuts to Medicaid and access to medical care, as well as SNAP benefits. In particular, this will hit folks living in rural areas of the United States. So, Dr. Pate, here's where I want to begin our conversation. Can we talk about how Medicaid actually works? This is why I think this is important, because we have heard certain legislators, in particular, Speaker of the House Mike Johnson, saying that we don't want people like able bodied young men to, quote, game the system and not work and still receive Medicaid benefits. Can you talk about the misinformation around that idea? Because, number one, Medicaid is not like Social Security. People who are on Medicaid don't get a check in the mail every month just in case they need medical care.
Well, that's right. And, if there are these able bodied men who are not working that are on Medicaid, I have not seen it. That doesn't mean they're not out there, but I haven't
Mm-hmm.
seen anybody show us that that is actually a problem. Perhaps it is, but I haven't seen anything to indicate that is. The people, when I was in medical practice, the people that I took care of on Medicaid were people I can't imagine anybody would have an objection to. These were people who were severely disabled. These are like, I had a patient who had a very rare disease, which meant she could move almost no of the bones in her body. She was confined to a wheelchair. She was dependent on other people for everything, for food, for transportation, everything. When I would see the typical Medicaid patients, these were people who were destitute, were not wanting to be on the Medicaid program, and typically I rarely saw men on it. Typically, it might be a mother with a number of children who needed support, and it's not a system that I have seen that reflects what I've heard people talking about. Now, and it's very difficult to get on. There is a lot of checking and process you have to go through before you can get on to qualify. And if it were not for Medicaid, we're talking about people who would not otherwise be able to get health care. And let me tell you what happens when people lose Medicaid who cannot work. Now, understand, I'm not talking about the situation where the person is able-bodied and just chooses not to work. If there are those people like the speaker is talking about, I share that sentiment. I think you shouldn't
Mm-hmm.
be on Medicaid. But what the issue is for us is how difficult is it going to be? How to what lengths are these people who truly need our help and need Medicaid, what are we going to put them through? What are the hoops they're going to have to go through? Because If it's something that's complicated online, a lot of these patients don't have access to the internet, and may not have computers at home and may not be computer literate. If it's something where they have to go show up someplace, a lot of these people struggle with transportation. So, how hard are we going to make it? And as a result, are we actually going to kick people off of Medicaid who cannot work and who really need our help, and now they won't have insurance? And what happens is that those people don't seek care early. When it's
Hmm.
easy to take care of a problem, they get sicker and sicker, and then what they do is they show up in the emergency room of the hospitals, and hospitals are required to care for them even if they can't pay. And then now that burden shifts from society and Medicaid to the hospitals to pay for these people's care. And I used to do this all the time when I was taking care of patients with Medicaid, even when they had Medicaid. There's a Once they got it, we're getting out of the hospital. There's a lot of places that just won't accept Medicaid, and you can't send them to. And a lot of times, I was having to make decisions about what the hospital was going to have to pay for, even when the patient went, because we couldn't just send them home or send them to the streets. You got to care for them. And so this is a huge burden that will transfer onto hospitals. And as a consequence, we're going to see a lot of bad things happen in Idaho to our hospitals, particularly rural hospitals.
Well, and Dr. Pate, also the idea that it's this idea that someone's getting some type of monetary benefit. They're not getting a check, and it is to allow someone who's on Medicaid to have access to medical care. Right? If someone is diagnosed with cancer and they're on Medicaid, they get cancer treatment. If someone who needs Medicaid doesn't have Medicaid and they're kicked off the system, the likelihood is they're not going to get that cancer treatment. So then we have the issue that you brought up, which is preventative medicine. All the research shows that preventative medicine makes all of us healthier. It is communal. Can you talk a little bit about that?
Yeah. So, first of all, um, when we have preventive services, remember that people on Medicaid are somebody's family as well. They are parents, they are children of parents, they are people who are loved. And when you see that, for example, this person cannot get any health care. And now they can't get screening mammographies. So they might not get an early breast cancer diagnosis. It might be a later breast cancer, and one that's going to be much more and more expensive and difficult to treat. When you don't have preventative care benefits, you're not going to see early diagnosis of high blood pressure. And so we know that's going to lead to more strokes. And that person then may have to receive extra care and can't care for another family member. That now becomes a problem. When you can't get preventative services, you don't diagnose diabetes early, and you see more complications from that. There's all these problems. Plus, if they can't get vaccines, they're going to get these vaccine preventable diseases. We're going to see
Hmm.
hospitalizations. We're going to see deaths. We're going to see people with consequences from it. And you're not making America healthy again. You're going to increase chronic diseases in Americans if we do this.
So I want to talk now. You mentioned rural hospitals, hospital associations across the country. Um, are warning that Medicaid cuts could lead to hospital closures. In fact, I believe the Louisiana Hospital Association sent letters to the Louisiana senators, sent letters to Speaker of the House Mike Johnson, saying like hospitals will close if this bill passes. It's not just it's hospital closures, it's reduced services, it's staff reductions. Dr. Pate, we are a rural state in Idaho. We already have health deserts. We already have a shortage of doctors. What will the true impact of a bill like this be for Idaho?
Well, it's going to be huge because people don't understand, and I don't fault them at all because this is hugely complicated, but all the interconnections between Medicaid and all of the health operations in the state. Um, Now, rural hospitals, and you look at a state like Idaho, like you said, we would expect that somewhere between 75,000 people would lose coverage here. And a lot of those people are going to be disproportionately in rural areas, which means now when those people get sick, they're going to those rural hospitals. They're not going to have coverage. The rural hospital is going to have to pay for it and lose that money. And that's going to be a harm. When I was still CEO, I don't know today, but when I was still CEO, I interacted with many of the rural hospitals around the state, and many of them were teetering on the edge of insolvency. Any one kind of blow to their finances could tip them over. There were some hospitals in Idaho where boards of directors were having to come up with cash to loan the hospital so they could meet payroll for that upcoming pay period. That's how fragile they are. There is no question that something like this, where now they are taking care of a patient that they would have gotten paid under Medicaid, and now they won't get paid anything, that can be enough to tip them over. Medicaid also in these rural hospitals that disproportionately take care of Medicaid, they were used to getting extra payments based on that disproportionate share because Medicaid doesn't pay the full costs of the care. And so they could lose that. And then what happens is if you're a rural hospital CEO and you're faced with not making enough money, you have to do one of two things. You have to either lay off people and reduce expenses, like closing programs and access, or if you can't get through it that way, because there's not a lot of fat in these rural hospitals, then you're going to either just get acquired or you're going to close. And this will be a problem. And then if a rural hospital closes, realize that for many places of Idaho, you're now going to be talking about those people in that area that were previously served by that rural hospital now may have to drive 2 to 4 hours to get to the next hospital where they can go. Those hospitals are already busy, and now you're going to add all of these people on. It's going to mean longer waits in waiting rooms. It's going to be more congestion. It's going to put impacts on those hospitals and strain the system. And then, like I said, the other problem is once you have patients in the hospital and they need to go to rehab or need to go to assisted living or need to go to a nursing home or whatever, we're going to find that more and more of those organizations will not be able to take these people without the Medicaid. And the estimate is that perhaps up to 20% of nursing homes and assisted living facilities will close as a consequence. So it all backs up. It's going to, even if you are not on Medicaid, it will end up impacting your health care indirectly. And as you added, I haven't even touched the fact of what this is going to do to hurt our efforts at physician recruitment, because when we put physicians in rural areas of Idaho and recruit them there, they have very important ties with those local hospitals. And if those are gone, not too many physicians are going to want to come.
And as you mentioned, Dr. Pate, right, even if you're not on Medicaid, even if you live in an urban area where you have access to medical care, right, we're already seeing this in Idaho. If you don't have a primary care doctor, it is hard to find one. And I would think that that is going to be even more difficult, or if you need to see a specialist, right, it's going to take even more time to do that.
I think everyone will feel the effects. Maybe not day one. It may unfold over the next few years. But yes, this is going to cause so many ripple effects, and it's going to be to the detriment of everyone. So I really fear this. I understand from having run hospitals, run a health system. What this is going to do, this is going to hurt physician practices, and we have. We just have such a fragile infrastructure as it is. I just think this is not going to be good, but people won't realize it until it's too late.
Mm. So the number of measles cases in the United States has quadrupled so far this year compared to 2024, nearing a 30-year high. That's according to CDC statistics. So, Dr. Pate, even though Idaho so far hasn't had any confirmed measles cases, however, just this morning, Wyoming reported its first measles case in 15 years. So I believe now there are 34 states that are reporting measles cases. So, what does this mean for Idaho?
Well, it means it's just a matter of time because, as you pointed out, this has now involved 34 states of the country. This is the largest outbreak of measles in nearly 30 years. I am quite convinced we will hit that terrible target over the rest of this year because this outbreak is not going to end this calendar year. I will be totally shocked if that's the case. I expect this to extend into next year. We're going to see many more cases. And with cases in the state of Washington, in Montana, now, as you just mentioned this morning, in Wyoming, it's around us. It's going to be here if it's not already here. And what it's going to do is it's going to give us an indication of what our real level of vaccination is in the state, because certainly in terms of reported vaccination, we are at a low enough level that we can expect measles outbreaks. It will be very reassuring if we don't have one, but I wouldn't bet a penny on that being the case. I'm sure within a month or two, I bet we have it here in Idaho as well.
Okay, so this is also what I wanted to talk about, Dr. Pate, and this is the fact that in 6 weeks from today and tomorrow, kids in Idaho, at least in Southwest Idaho, are going back to school. How will this impact students? How can parents prepare for this if they are concerned about this?
Well, the big thing is make sure that your children are vaccinated. And because the vaccine is highly protective, a single dose of the MMR vaccine is 93% protective. The two doses, one that children should get at the year to year and a half range, the other one 4 to 6 years of age. If you get both, it's 97% protective. And it's even more than that because even for that few percent that are vaccinated that might still get infected, to my knowledge, no one that's been vaccinated has ever died from the measles. So it's at least going to protect against that. And so if your child's entering school, get into the pediatrician or your family physician before school. Get up to date with vaccines. They're highly protective, and that's the best thing that you can do.
So, Dr. Pate, what about someone who may have a baby under the age of 12 months? Because that first vaccine recommendation is between 12 to 15 months. And in particular, what if they like have a kiddo going to kindergarten, right? And maybe they have an under 1 year old at home. Can they get a vaccine earlier? I mean, what do you do if you're in a situation like that?
They can. We have to assess what the risk is. And the reason is because children that age don't form as lasting a response. So we wouldn't
Mm.
want them to rely on that being their vaccination. But for example, if there was some need to take an infant on an international travel, airports are very dangerous for this kind of exposure right now. Lots of other countries, Canada's having a worse outbreak than we are. So some
Oh,
other countries, or if you have a child that is going to be going into a daycare or nursery, for example, and that is a daycare that doesn't require vaccinations, or that might be a group of people that typically doesn't support vaccination. Talk to your pediatrician. There are exceptions we can make, but of course, one of the best things is for those mothers who are pregnant, if you or planning to be mothers, because we wouldn't give this vaccine once they're pregnant, but if they're planning on getting pregnant, get the vaccine, because you can transfer those antibodies to your baby and help protect them for at least the first 6 months of their life, and you can even pass it in your breast milk to them and protect them.
All right. Well, Dr. Pate, as always, we so appreciate you. Thank you so much for all of your fact-based information. It is so helpful as we move through this. We've been speaking with Dr. David Pate. He is the former CEO of St. Luke's Health System and the co-author of the book, Preparing for the Next Global Outbreak. Remember, if you have any questions in regards to public health, send us an email, idahomatters@boisestate.edu, and we will send those to Dr. Pate for him to answer on air. This is the Idaho Matters podcast. I'm Gemma Gaudet.
These days, there's so much news, it can be hard to keep up with what it all means for you, your family, and your community. The Consider This podcast from NPR features our award-winning journalism. 6 days a week, we bring you a deep dive on a news story and provide the context and analysis that helps you make sense of the news. We get behind the headlines. We get to the truth. Listen to the Consider This podcast from NPR.